First of all, let me thank you for the invitation to participate in such a distinguished event, one that is so important for the development of Asian cardiology. Until recently, as you know, in 2017 European Atherosclerosis Society expert consensus concluding that LDL cholesterol is the principal cause of atherosclerosis. Only a year after that, the consensus highlighted that lipoprotein A, the silent, invisible, and killer, as playing a major role in atherosclerotic cardiovascular disease and in aortic stenosis. And so our task has grown more complex. We now face not one but three enemies: LDL cholesterol, triglyceride-rich lipoproteins, remnant cholesterol, and lipoprotein A. All three are ApoB containing, and together they drive the development of atherosclerotic cardiovascular disease. On the slides left, you can see three particle tips crowding at the door, the endothelial entry point. On the right, you see them streaming in, all three inside inflammation, and are taken up by macrophages because their size is under 70 nanometers. In 1973, the Greek scientist Akira Endo gave us a gift. He isolated the first statin from a mold, Penicillium citrinum. A rhetorical question arises: what can a medicine from mold actually do? But that medicine became our most reliable weapon for a long time. Here are the results of meta-analysis over 5 years in 175,000 patients. Statin therapy lowering cholesterol by just 1 millimole per liter was associated with 21% reduction in all major cardiovascular events, 24% in coronary events, 24% in PCI, and all. This, of course, is a major achievement, milestone in cardiology and medicine. But statins have a flip side. While saving 20%, 30%, even 35% of our patients, they unfortunately do not save the other 65–80%. Hence, the well-known concept of residual risk. At least 5 dyslipidemia-related factors contribute. On the right flank, you see triglyceride and lipoprotein A. On the left, failure to reach target LDL cholesterol levels. Further, high sensitivity C-reactive protein, also a consequence of oxidized LDL and triglycerides driving vascular wall inflammation. Back to the right flank, residual diabetic risk, the so-called heterogenic triad: high triglycerides, small dense LDL, and low HDL cholesterol. I left one empty niche: residual thrombotic risk. And if we discuss lipoprotein A, it's exactly the lipid that raises residual thrombotic risk. But statins, in addition to their benefits, revealed vulnerabilities, most notably resistance and intolerance. Some patients cannot tolerate statins at all, and some cannot tolerate full guideline recommended doses due to adverse effects particularly muscular symptoms. Here is resistance. By week 4 of atorvastatin 80 milligram, blood levels of PCSK9 rise 1.5-fold, making statins less effective. On the right side of the slide, instead of further LDL reduction, you even see a slight increase. This vulnerability leads to a higher risk of major cardiovascular events in patients with elevated PCSK9. But humanity does not stop advancing. Monoclonal antibodies were created to block PCSK9, and injection once every 2 weeks or once a month lowers LDL cholesterol. If we skip the injection, after 2 weeks or a month, LDL cholesterol rises again. In this way, we can potentiate statin action and overcome resistance. The most convincing demonstration came from Fourier trial. 28,000 patients over 3 years. Average LDL cholesterol reduction was 30 milligram per deciliter, yielding a 15 benefit in composite endpoints. Those myocardial infarction, stroke, hospitalizations for destabilization, and coronary revascularization. However, there is a but. The reduction of cardiovascular dose that statins once handed us on a platter was not achieved in this study despite combination therapy. We moved forward, but not to perfection. Work continued. As always, nature held a clue. Loss of function mutation in PCSK9, such as R46L, occur in 3-4% of Western Europeans. Yet, when we studied 300 patients with ischemic heart disease and 100 healthy individuals in Uzbekistan, we found no carriers, meaning the mutation is even rarer here than in Europe. And the next step, small interfere RNA, cRNA, to inhibit PCSK9 without touching DNA. When I spoke about residual risk, I showed the classic academic diagram. More vividly, triglycerides are the fire of inflammation, to use Peter Libby metaphor, and elevated triglycerides are present in a quarter of our patients. In Copenhagen data, high sensitivity CRP is markedly higher in patients with elevated triglycerides compared with those with isolated LDL cholesterol elevation. A new biomarker, lipoprotein A, exerts pro-atherogenic, pro-inflammatory, and pro-thrombotic effects. Experts estimate it's elevated in 20% of the population. In Uzbekistan, that's almost 7.6 million of 38 million people in 2025. In Russia and China, even more. This serpent has 3 hits. First, atherosclerosis progression, second, inflammation, and thrombosis, each proven for lipoprotein A. At the ES Congress in Glasgow, residual risk was depicted as lightning bolts striking patients: LDL cholesterol, high sensitivity CRP, high triglycerides, and elevated lipoprotein A. I like this article, Knight in Shining Armor. It named statins the first knight in shining armor, but as we know, 10 or 20% of patients cannot tolerate them and are left with risk due to elevated lipoprotein A. Monoclonal antibodies to PCSK9 are boon, but not a panacea. Their uptake is slow because of cost and limited data. Some patients don't want injections every 2 weeks or monthly. Adherence is a challenge. A new contender appears, Inclisiran. Inclisiran is a double-stranded small interfere RNA targeting intracellular RNA and blocking the synthesis of PCSK9. It lowers PCSK9 inside and outside the cell, and its chief advantage is just 2 injections a year. If you miss a dose, it's easy for the physician to remind the patient. The objective of our study was to assess the efficacy of Inclisiran as part of combination lipid-lowering therapy in targeting K residual risk pathways in patients with chronic coronary syndrome in Uzbekistan. In September 2024, patients received their said 1 year of therapy. The cohort included equal numbers of men and women, average age 57, 60 years, 25% had diabetes, 20% were smokers, nearly 30% had BMI more than 30, 33% had prior myocardial infarction, 50% have undergone stenting, and 6%, 20% were statin intolerant and took ezetimibe only. In results, total cholesterol fell by 35%. Triglyceride levels have significantly decreased, LDL cholesterol by 61%. High sensitivity CRP decreased, epicardial fat thickness diminished. According to the 2019 ESC/EAS guidelines, 73% of patients achieved the target LDL cholesterol less than 1.4 millimoles per liter. It is known that Inclisiran powerfully lowers LDL cholesterol, but it needs in orchestra. To accompany it. Adjunctive therapy, statins, ezetimibe, fenofibrate, omega-3 plays an important role. In pooled phase 3 data from Wright et al. Demonstrated a 26.5% reduction in LPA values compared with placebo in Orion pooled trials. And in conclusion, 1-year treatment with Inclisiran was associated with reduction in K residual risk drivers in patients with chronic coronary syndrome in Uzbekistan. Thank you for your attention.